Welcome, everyone. I'm Dr. Tara Kiran, and I'm going to be your host today. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that we can continue to bring you these sessions, changing the way we work, coming together as family doctors around COVID-19, together with the Ontario College of Family Physicians. So to that effect, I'm going to turn it over to Liz Muggah, the current president of the OCFP.
Good morning, everyone. Looking forward to our session today. It's going to be terrific. We had more than 900 people register, so can't wait to get started with all of you and share in this conversation. Those details are there about the main pro accreditation. Next slide. So I'll read the land acknowledgement. We acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Back to you, Tara.
There's obviously so much that we can reflect on in terms of past and those present injustices perpetrated towards Indigenous people. But one thing that I wanted to highlight today was some research done by my colleague Janet Smiley that really showed the increased incidence of COVID-19 among urban Indigenous, specifically those in Toronto, and the increase in the disproportionately high hospitalization rates among Indigenous people as well. So, really a reminder to us that Indigenous people in urban areas have suffered, and that we need to do everything to get them the vaccine, and that, to some degree, many Indigenous people in urban areas have still not gotten it, and it is one of the groups that we need to focus on. Next slide. So this slide is just reminding you that this is part of a series, and of course, you can access our past sessions at the DFCM website. These past sessions are also Main Pro accredited, and I know many of you have questions about the vaccine. That I will say, Allison, we've had Allison McGeer on multiple times, and she's done an incredible job answering some of those. So please do check out our past sessions. Next slide. So without further ado, I'd like to just introduce our panelists, and I'm going to turn it over actually to them one at a time so that they can introduce themselves and speak to their conflicts. Abhishek, do you want to go first?
Sure, thanks so much. Good morning, everyone. My name is Abhishek Raut, and it's a pleasure to be here. I'm the medical director for the Appletree Medical Group, and I'm also a board member for the Ontario College of Family Physicians. Before I served as medical director, I worked in the field of global health systems. So with partners like USAID, the World Bank, and Johns Hopkins, we designed nationwide performance metrics for countries such as Afghanistan to help create an integrated healthcare delivery and funding approach.
Brian, could we get the next slide, just with the one with the conflict? Great. And Allison, can you introduce yourself?
Thank you. Good morning. I'm Allison McGeer, and I'm an adult infectious disease physician at Sinai Health System in Toronto with an interest in adult vaccination. As you can see from my declarations, I have relationships with many companies that make vaccines.
David?
Good morning, everybody. I'm David Kaplan. I'm a family doctor in Toronto and the Chief of Clinical Quality at Ontario Health in the the Clinical Institutes and Quality Programs portfolio. I receive salary support from Ontario Health and receive an honoraria for doing these sessions from the Ontario College. Looking forward to today's session.
Liz?
Liz Muggah, as I said, family doctor in Ottawa, and I have a stipend that I receive from the Ontario College for my role as president.
I'm Tara Kiran, and as mentioned, I am a researcher as well and have a number of grants and salary support that I've listed there. The only one from a for-profit company is Gilead Sciences for some work on Hep C. Next slide. So thank you to all of you who are coming from all across Ontario to join us. I love the diverse perspectives that you bring, the questions that you ask. Next slide. As usual, we've designed the session based on what you have told us you want to hear about. We know that you also have lots of questions that you come with. So just a reminder to put your questions in the Q&A, and I will prioritize questions that receive the most thumbs up. So if you go to the Q&A, please start by looking at what questions other people have already asked and give a thumbs up if it's a question that you want, rather than entering it your own question in a different, slightly different wording. And then take a look at the answers as well, because our panelists do a terrific job typing answers. So the question you have may already have been answered in the answer section. So please take a look at that. And the top questions, though, will be asked orally to our panelists today. Sometimes there are things you want to share with us, and so please do use the chat function to share those things. I know so many of you have tips and tricks and are doing amazing work where you are, and I love hearing about that in the chat. As I mentioned, we've designed the session based on your feedback, and so we're going to be starting out today just talking about how we as family doctors can ramp up our own work in office and make sure that we're seeing the patients that need to be seen. We'll then kind of switch gears and talk a little bit more about vaccination again. And I know there's so much in the news all the time, changing evidence and policy, and Allison McGeer will speak to some of the latest and also answer some of your questions. And then we'll have David Kaplan tell us about these new reports that family doctors and patient enrollment models will be getting. He'll be going over the new reports, what those will mean, and how you can use those reports to identify your unvaccinated and start to have more of those conversations I know you're already having. So without further ado, I'm going to just turn it over to Liz. Liz, can you just maybe give us a quick intro into why we're talking about ramping up?
Yeah, so thanks. So I think, as we all know, we're in a new phase. At the beginning of the pandemic, we all were switched rapidly and very nimbly to virtual care. And now with vaccination rates increasing and COVID prevalence decreasing, looking at, what's our new normal and what's the right balance between in-person and virtual. So the OCFP released some guidance taking a look at this question, given our where we're at now. And I just thought I would share with you what the data is that we have. So if you look at the bottom, this only goes to January, but this is the information on in-person visits and the percentage that are in person, and then the total number of visits that we're doing. And what you can see here is that total number of visits is really coming back up to where we were pre-pandemic. And the average number of in-person visits, that's that dotted teal color down there, somewhere between sort of mid 40s to 50% in terms of what people were seeing in January. And I suspect now, could be higher given where we're at now versus where we were in January. And the next slide, which I think is interesting, takes a look at the same, so this is the same information now, again, only going from April to January, but it looks at it by region. And if you look across at the dotted lines, again, you can see that the percentage of in-person visits do vary from region to region. So, down somewhere near, somewhere in between that 30 to 40% in the Toronto region, and then higher in the north. And I think that reflects the prevalence of COVID in those different regions in part. So the average at this stage from when this data was taken was that on average, family docs are seeing somewhere around 50% in person. So we thought this might be a place to start, a guidepost to start. Clearly our decisions around who we're going to see in person versus virtual will depend on the patient, what the patient needs, taking that patient-centered approach that we're also familiar with, and then what the condition is. But I thought this was sort of useful for you to kind of see what's happening across the province. If we had data that was closer to now, I obviously would have shared it, but this is all we have from the ministry at this point. And the next slide just shows some of the information on cancer screening, which I thought you would find interesting over time. So if we just go to the next slide, so it looks at PAPs, mammograms, and colon cancer testing. I don't know if Brian, you can go to the next slide. Thanks so much. So again, this ends in February, but you can see sort of that difference. So again, 3 different lines with the 3 different screening procedures that we do. And then that drop that we saw, and then coming back up. Hard to know again where we're at right now, but I think we probably all know in our offices there still is a bit of a care deficit around some of these preventative maneuvers. So just thought that context setting was useful. Maybe I'll hand it back now to you, Tara, and I think Abhishek, who's going to talk a bit more on this sort of what's happening in some of our practices with as we return to the new normal or head towards a new normal.
Yeah, we'll go to the next slide, Brian. And I think it'd be great, Abhishek, if you could just give us an overview of what you've been doing in your practice and how you're balancing in-person and virtual visits. I think it'd be great for us to learn about what's happening and take some lessons away. Next slide. So over to you.
Right, so I was asked by the OCFP to provide a presentation really on the lessons we've learned with our experiences with virtual and in-person and telemedicine, and how we've been able to really ramp up in-person visits. The Appletree Medical Group has a total of 155 physicians and 52 health centers. Many of you from Toronto and Ottawa have likely heard of us, as 50% of our health centers are in Toronto and Ottawa. Our physicians provide comprehensive care to their rostered patients and also see walk-ins. And most of our doctors are practicing family physicians with roster sizes of 1,500 to 2,000 per physician. And we also have specialists such as OB, gynae, internal, pediatrics, and endocrinology. Model-wise, we operate as two FIGs, our family health groups, one based in Toronto and the other based in Ottawa. We received no additional funding from the ministry to implement our model. About 50% of our health centers are telemedicine sites. The physicians at one of our clinics, and we have a telemedicine assistant, prepare the patient's history and physical and present it to the physician. Virtual care is something we've been involved in for a long time now. We worked with the Ministry of Health as a pilot to cover virtual care services in 2018. So about a year, 2 years before the pandemic there. Over time, this has really allowed us to see the changes and trends that both physicians and patients prefer. Let's go to the next slide there. So here's our breakdown so far for the first part of 2021 for in-person virtual care and telemedicine appointments across our health centers. 45% of all visits were seen in person, 50% were seen in virtual care, and 5% in telemedicine clinics. So I find this fascinating because this mix is likely going to be part of the future of our profession. The HMO group Kaiser Permanente had said in 2018 that 60% of all primary care visits could be handled safely using telemedicine and virtual care. But as a corollary, that means 40% is not appropriate for virtual care there and requires that in person. When we look at virtual care, we really have two mediums. We do phone or video. We only keep the phone option in order to facilitate those without internet access. But the truth is, video is much safer than phone. And even seeing the patient, even heuristically, gives you a good handle on the issue in question. Things like pain, discomfort aren't very well communicated over a phone medium there. So over time, most of our physicians have preferred video, and many of our physicians only do video and in person as opposed to phone. We use an InSig software, which allows us to switch from phone to video as well if we think it's appropriate based on what the patient has written. Let's go to the next slide. So the first question the first lesson we really learned that it had to be crystal clear to the patients on what they could use virtual care for and what they could not. So we chose these exclusion criteria because we don't think these are necessarily safe for the patient over virtual care. We believe that virtual care is really just a tool to improve the continuity of care. It is not a replacement for in-person completely. What we see here is controlled substances, narcotics, chest pains, abdominal pain, shortness of breath. In fact, we had initially so many patients booking into virtual care with chest pains that we had to write it twice in our exclusion criteria. So you see it's actually written twice there. Allergic reactions, choking, altered level of consciousness, head injury. And with the exception of our pediatricians, most of our doctors see children, but over the age of 4, which we think it provides a much safer age group for a virtual video medium. Next slide. After this, what we see here is what we believe can be safely seen on virtual care. Each of these eligible conditions has a unique survey that's sent to the patient. So for instance, the acne survey, patient is asked about the different treatments they've received, and they're able to take pictures of it as well. What I wanted to draw your attention to is this one called "Do I Need to Come In?" Because oftentimes the patient is not sure, and having this visit type allows us to speak with the patient who presents with an undifferentiated presentation. In this capacity, a doctor is offering two guidances: when to see a doctor in person and when to go to the emergency room. Another one that's been successful has been, I have questions about my ongoing condition and I want to follow up on my lab tests. I think this is the part that's going to really shift. I think patients will have difficulty seeing their doctor in clinic to do lab test reviews and the rest. That might be best handled and a better use of time for the patient and the physician if we do it virtually there. So patients are really grateful to be able to speak with you on a concern that they have never brought up in an appointment in person. And sometimes that 5 to 10 minute call is very reassuring to the patient. Next slide. Another lesson we learned to make sure in-person visits are safe was that we needed to do screening using multiple tools and multiple mediums. So we needed to create a culture of patient responsibility and safety as well. So the expectation of any Appletree patient is that they will be undergoing 3 separate screens before seeing a doctor in person. It sounds intimidating, but it really is not. The first one is passive screening. These are the signs in clinic and on our website. It asks the typical questions: fever and cough, travel history, or contact with possible cases. And based on that, we try to differentiate. We ask them instead to use virtual care first before coming into clinic. Of course, we also write in those that if they're having concerning symptoms, difficulty breathing, to contact public health or go to the nearest ER as appropriate. After all of that, the patients who register in clinic at our automated kiosks are prompted with a message on the screen to sanitize their hands and leave the clinic. So that ensures minimal transmission of COVID-19 in our waiting rooms. The patients are instructed to wait outside for a phone call in order to be called in. So we learned that patients do also want to keep their doctor safe, and there's really been minimal protest on asking the patient to leave the clinic while they wait. I think it's helpful to note that retail stores, especially in Toronto and Ottawa, have already implemented something like this. So this culture is almost normalized now. And finally, the patient will be then screened verbally by our medical assistant as well, usually over the phone. They have to pass the screening questions again. So fevers, cough, difficulty breathing, travel history. And what we do is we can look at the combination of symptoms there and then determine what would be the next step there. If a patient comes with cough and fever or any of the other questions, we direct them to sanitize their hands, put on a mask, and follow next steps, which is either booking virtual care or seeing if the doctor is willing to see them. The physicians can add to all of these symptoms, but they can't see patients who really fall below these categories for safety purposes. So after the patient has gone through all that screening, then they're taken into a room and triaged before the assessment by the physician. The patient tests positive for the screening, we inform the physician, and sometimes it is a known patient with a different ailment. So this 3-pronged approach has really helped us take care of many of our patients who may not necessarily be truthful in their initial screening, but with subsequent screenings end up being so. Next slide. I'm going to just very briefly touch on this here, but basically lessons learned from PPE is the higher levels of PPE allow you to do more in clinic. It's uncomfortable, sure, but the risk is significantly decreased. And PPE is really only as good as the user. So while we're familiar with our usual face shield and isolation gown recommended with respiratory symptoms or a positive COVID-19 contact, it's something that we keep in mind as well. So all staff are working in our clinics triaging and speaking to the patients. They have to wear a mask and the patient has to wear a mask as well before entering clinic. And our team members are required to wash their hands before and after each triage of a patient. So are our protocols a higher standard than many public health agencies? Probably. And that's because in order to practice safely, we need to reach those minimal safety requirements that are established and then go higher up for our patients. Next slide. So for my final slide, I wanted to touch on screening very. What we've seen over the past 12 months is an unprecedented reduction in preventive screenings. That's something that I believe our profession really needs to fix as soon as possible. So how do we work on this? We're actually using almost the same tools from our screening approach. For passive screening, we provide information for patients on our website about their screenings, when they're due, and how they can book them via our patient portal. For active screening, when a patient attends a virtual or in-person appointment, they've got to fill out an automated triage questionnaire. Once they've finished answering all of those questions related to the visit, the software will then prompt them for preventative screening questions, such as pap smear, mammogram, fecal immunochemical tests. So based on their answer, we alert the doctor in the history, and they're able to assist in those preventive screenings. But if you can't address it at that visit, then we add these patients to a list and then call them to make sure they get a screen. I think really we have a lot of work still to do in this area, and we're also exploring how to really incorporate our other screenings, particularly mental health and even routine STI screening based on new guidelines. All right, well, before I end, I just wanted to say thank you everyone for all your hard work during the pandemic. I think this, as a profession, we've really stepped up to ensure our patients' health should not be jeopardized. I really couldn't be prouder to call myself a family doctor during these times. Thanks so much.
Thank you so much, Abhishek. So, I think that there's been some really interesting chat as you've been giving your talk, actually, with a lot of interesting comments. I mean, I think a couple of people have pointed out that, for many people, they don't have good Wi-Fi and it is hard to do video. I will just mention that we have done some patient experience surveys among our 14 teaching sites associated with the University of Toronto. So these are sites that are all over the GTA, including up to Barrie. And we did find that 90% of patients are, more than 90% of patients are very, very comfortable with virtual care, phone, email, and video. But actually that comfort level is less for some groups, including people who have difficulty making ends meet, who have reported that they're newcomers to Canada, and those people with poor fair health. And those same people actually are less likely to say that they want those virtual modalities to continue in the future. So I think that's a great point that some people made, but it sounds like you also do offer phone visits. But the one thing that I'm going to pick up that somebody asked is just this. So Shalini Rastogi said, the biggest hurdle in seeing patients in person is IPAC guidelines, social distancing, and logistics to run full clinics and patients. So I wonder if you or maybe Allison could actually speak to that, or Liz, in terms of the IPAC guidance currently.
Yeah, I think Allison can probably speak to that there.
Yeah, I think, we're still stuck with the recommendations right from November 2020 about practice in the office. And the issue here is that even though things look fine now, what's going to happen with Delta is not clear. And I'll show you in a minute what is making people worried about it. And so I think the sit tight in the face of we want to reopen, the sit tight is because we just don't know what Delta is going to do in the next 2 months. And so I think the ministry is unwilling to just say, let's go for it. I'll show you the numbers in Spain and the UK. It does make it extraordinarily difficult. There's no question. But I think I know this is the patience of Job, but it just needs patience to wait for the next change.
Allison, so I think with that segue, why don't we turn it over to you, Allison, and it would be great for you to give us a little bit of an update on where things are at. I know many people have questions about Lambda, Delta, and myocarditis.
Okay. So I want to start for a moment. There are a lot of questions about vaccinating kids. So let's talk for just a moment about where we are with vaccinating kids under 12. it is a difficult and complicated space. And I think you're hearing a lot of people ranging in Ontario from, I think, David Fissman on the side of we're really going to need to vaccinate children because they're a significant reservoir, to a number of other expert pediatric ID folk who are thinking that the risk-benefit ratio is not positive for children. So still a wide range of opinion because we don't have enough data. And the data we need are burden of multisystem inflammatory disease in kids, burden of long COVID in kids, what's going to happen with Delta, because Delta does seem to be shifting to younger age groups. What does the disease look like in children with Delta? And what does, how big a risk are asymptomatic or minimally symptomatic kids to other people? All of those things are open questions. And in addition, it's looking like we're not going to have the less than 12 clinical trial data from the Pfizer and Moderna vaccines, they'll be first, before September or October. So we're just October or November at the very earliest is when we're going to be moving to a recommendation for kids. And that just can't be fixed. We simply have to wait until we have enough data. And what that means is, for all of us, is that public health recommendations about what to do at kids under 12 are going to be a mess for the next 3 or 4 months. It's going to be different in different jurisdictions, and all you can do is, follow what your jurisdiction is telling you to do about kids. If you're traveling with children, check the rules carefully before you go so that you know what's happening. It's one of those really frustrating things, but it just isn't going to get better for some time. Okay, so that's kids. Secondly, let's talk myocarditis after mRNA vaccines. There is this week, I'm sorry, I think I cut and pasted it into the chat. There's a new MMWR report out from the CDC that has some nice additional data on myocarditis, if you're interested in looking for it. And so I just wanted to point out, in the discussion about first dose and second dose, what you see on this slide is a cut and paste from 2 of their tables, looking at the comparison between dose 1 and dose 2 in women and men, and how the observed rate compares to the expected rate. So one of the problems with myocarditis is if you just take all comers with myocarditis, there's a baseline rate and there's no detectable difference. And the reason there's no detectable difference when you look overall is that this problem is totally focused in 12 to 29-year-old men, maybe 12 to 31-year-old men, okay, but really young men. And that may not be surprising. Myocarditis in general is a disease of teenage males, okay? We don't understand why, it just is. So when you look at this, when you look at dose 1, the only excess myocarditis is in 12 to 24-year-old males. Okay, here's the expected here and the observed, and it's about 3 times the baseline rate. So it exists, okay? It's on the order of 1 in 100,000 or 1 in 200,000, but it's really uncommon. And the information we have so far, still data coming in, is that this is relatively mild disease. Okay, so it's not like VIT, which has a case fatality rate of 15 or 20% and causes a lot of other complications. It's probably much less severe disease, but we're still waiting to see what happens. In contrast, when you look at dose 2 with the mRNA vaccines, now you're looking at rates that are about 20 times the baseline rate. So this is really a dose 2 focused issue. No reason to worry at all about dose 1 of an mRNA vaccine in 12 to 29-year-old men. Of course, you want to tell people about it. You want them watching for myocarditis, but it's still, it's not a risk that is higher than the risk of anaphylaxis. And very clearly, when you can just go to the next slide. If you look at the balancing act, so this is now for 2 doses, but on the, sorry, my people are getting in the way of my looking at what's on this slide. So first dose risk 1 in 100 or maybe 1 in 200,000. Second dose in 12 to 24-year-old males. Now you're talking about some number between 1 in 16,000 and 1 in 20,000. And looking on the right side of this slide, you can see that at rates of COVID in the US at the end of May, which is about 3 times our current rate in Ontario, the balancing act between myocarditis and ICU admissions were roughly equal for second dose. Now, an ICU admission for COVID is considerably worse than myocarditis. And so you can see why NACI and the CDC are saying second dose vaccine in 12 to 17-year-olds is a good thing. You also want to look at this. So this is only vaccine efficacy for 120 days. And we know the vaccine is effective for more than 120 days. So it's an underestimate of the benefit of vaccines. On the other hand, at the moment, the rate in Canada is low. On the other hand, Delta is coming, right? So when you factor all those things in, what you're hearing from NACI and the CDC is Delta is coming, our case rate is going to go up, we want to reopen schools. When you look at all that balancing, the risk of COVID still in Canada is higher for 12 to 17-year-olds than the risk of myocarditis after second dose vaccine. So the NACI recommendation remains, unless you had myocarditis, previous history of myocarditis from first dose of vaccine, teenagers should be getting their second dose of vaccine with informed consent about the potential risk for myocarditis. But you can also see with this why some people are anxious about it and why some people are going to choose to defer second doses for another 3 or 4 weeks. And hopefully in another 3 or 4 weeks, we will have more data both on incidence, but also more data on the outcomes in the patients that the US is seeing. And, the evidence we have so far is that disease is mild, but it's not absolute. Okay, next slide. Okay, now the question comes is, what's making me anyway so anxious about what's coming in August and September. So this is the Our World in Data map of COVID cases over time. And what you can see is that there are now a number of countries. So the United Kingdom, Spain, and if you look right at the bottom, Israel, okay, even though Israel's case numbers are still really low, they were functionally at 0 a month ago. And now they have COVID rates that are a little higher than Canada's, okay? And that's called Delta. Delta's got a reproductive ratio of 7, okay? This is measles territory, okay? It's really unpleasant. Lots of places are having trouble dealing with it. And 2 things about this slide. The first is that a piece of the differential between numbers of cases is about when Delta got introduced and how quickly it takes over. And the first introductions of Delta from the Indian subcontinent, where we just don't have enough data to really know clearly what's going on, are the United Kingdom. Spain was a little bit ahead of Canada. In Canada, Ontario is leading in Delta, okay? So you're gonna look and say, well, Alberta's not as bad as Ontario, and you're right. That's because Alberta doesn't have as much Delta yet, okay? They're running 3 weeks behind us, and 3 weeks is a lot in this. The United States, like Alberta, is behind Ontario, okay? So you look at this and you say, okay, there's a bunch of countries that have Delta that are getting into trouble. Ontario and Germany are doing fairly well. And now look at the stringent public health measures stringency index, okay? People are looking at this and saying it's probably true that the reason that Germany and Ontario are doing better than other places, even though we're only a little bit behind them in terms of Delta introduction, is because we have more stringent health measures. And if we move to, say, Spain, which is what phase 3 looks like, which is supposed to be coming in a couple of weeks, then we may see the same increase in cases that Spain is having. And so that's the anxiety about what's happening with Delta is if we release restrictions, are we going to see, we definitely are going to see an increase in cases. You can already see us flattening. Okay, we're stuck at about 200 cases a day in Ontario. It's going to go up. The question is how much? And that's something we don't have an answer for, because what's going to stop it from going up is increasing vaccination. And, we're all scrambling to get as many vaccines into as many people as we can to try to stay on top of it. But we really don't have a good sense of whether we're going to look like Spain or whether we can hold because our vaccination rate's going up fast enough to be able to maintain. The other really interesting thing over the next period of time to watch is going to be what's happening in the UK, because what the UK is saying at the moment is that their hospitalization rate is not increasing dramatically, right? The argument is that yes, cases go up, but they're not as severe because people are vaccinated. And so we'll tolerate a case rate as long as nobody gets hospitalized, right? So, so the UK is arguing that they can continue to release precautions. They will get a lot of cases, but they will have very few hospitalized cases, very few cases of severe illness. Now, you will remember that last year, the UK said they were going for herd immunity and then decided that was a bad idea. And I think many people think that the UK is going to change their mind sometime in the next month. But, that's a really important outcome for us, because if the UK goes forward, they're a month ahead of us in terms of Delta, maybe 6 weeks. If they don't see hospitalizations, if they don't see deaths, or at least not very many, then we may well be willing to move much more quickly to releasing precautions. If, on the other hand, 3 weeks from now, they change their mind and start to go back into indoor masking and restrictions on large events, then we're going to be rethinking what we're doing. So the next sort of 3 or 4 weeks is going to help us a lot with how quickly we can release precautions and how quickly we can move back to normal. I think that's the last slide, yes?
Yeah, thank you so much,
so just
Allison.
One last comment on Lambda, because lots of talk about Lambda. Lambda is also known as C37. It's a predominantly been in South America. In South America, it's definitely outcompeting the original Wuhan strain. It's giving B117 a run for its money. And like the other variants, you're probably not as well protected by vaccines. So it's like Delta and now I can't even get them straight. Gamma. It's like Gamma and Delta in terms of vaccines are probably not quite as good, but it's just too early to tell what's going on. We have, I think, 37 cases in Ontario. The first case is months ago. So it's not expanding rapidly in Ontario, which is nice. But we are going to have to wait to see where it goes. Thanks.
Thanks so much, Allison. I think you've answered a lot of the questions that people had put forward. I'm going to ask one additional question that's come to the top for many people, and that's this issue of booster doses. So Jordan Effects, please comment on the need for booster doses, especially for those of us who were vaccinated 6 months ago. And then, of course, that's on the heels of I woke up to the news this morning about Pfizer requesting, authorization in the US and the UK for that third dose. Are you able to speak to that, Allison?
Yeah. So I think the first thing is that we really need to focus on getting first and second doses into people, because that's critical to protecting people from severe disease. And so there's an element of we don't want to be removing the focus. And that includes like some of the questions about extra doses for people who've had Sinovac or Sinopharm. Yeah, we might want to talk about additional doses for them, but we really need to get first and second doses into people of anything first before we talk about that. For healthy adults so far, protection seems to be holding out 6 or 7 months. And we know that from people who were infected, that protection holds for at least 9 months. So I don't think there's any reason to worry at the moment that healthcare workers will be less well protected. We're probably good for at least a year, okay? Immunocompromised, residents of long-term care, those are different issues, okay? And I think we may well, by the fall, be talking about a booster dose for those very high risk groups of people. The key questions are, How well do they respond to it? All right, we've already seen that third dose in immunocompromised people does not work as well as you would like it to, okay? So the questions are, does third dose work? And also, do you need it at a population level? Just because antibody declines does not mean you're not protected. Think hepatitis B vaccine, right? You just have to have a level once and you're okay. And so we still don't know that for COVID. So there's lots of preparation going on for COVID. If you want to look at what the recommendations are, the JCVI, the UK body that recommends vaccines, has a nice summary of who will probably give third doses if we're going to have third doses. But we're really holding to watch and see whether third doses are going to be necessary. And the final thing, of course, is that both Pfizer and Moderna, well, and everybody else, truthfully, although everybody else is a bit further behind, are building vaccines that have variants in them. So it might actually be worth waiting until we have those vaccines that give you better variant coverage to give the third dose, even to immunocompromised folk.
Awesome. So I'm going to take us back also to your comments on myocarditis, which I know many people appreciated. It's such a nuanced and tricky issue with the evidence evolving. So I noticed that you replied to Carrie Bernard, who asked, how are we supposed to advise people with possible myocarditis after the first shot? So if somebody had myocarditis at the first shot, what should we do? And I guess the other question that I'm seeing pop up quite a bit is, should we be delaying that interval between the first and the second dose? Is there any evidence to guide that? It seems like some public health units are kind of taking that kind of stance and others aren't.
Yeah, so to me, there's absolutely no evidence that the gap between doses of an mRNA vaccine is going to have any impact on myocarditis. In fact, if anything, if you look at it, the risk with Moderna looks a little higher than with Pfizer. And that, and the kind of logical conclusion, although it's still speculative, is that that's because Moderna is a higher dose vaccine and there's something dose related. If that's true, then extending the interval might actually increase the risk of myocarditis because you get a better boost, right, with antibody if you extend the interval. So in that setting, shorter might be better, but really all of this is speculative. There's probably very little difference when you give the vaccine. So second dose of vaccine is like 28 days plus for mRNA vaccines now. And so you can go as long as you like, but you can go at 28 days. Don't think it makes a difference. And your first question is so people who've had query myocarditis, I think at the moment, cases are down, things are going reasonably well. These are generally people who are young and healthy, where first dose is probably going to protect very well against severe disease. And so I think my advice to them is you wait. You sort of think about assessing whether it really was myocarditis or not, right? Because there's some of those people with query myocarditis that you might be willing to give a second dose to because it really seems unlikely. But there are other vaccines coming, right? I know I keep saying that Novavax is coming and I don't understand, and we're not going to have a lot of doses, but there will be other vaccines by the fall. And when those vaccines are available, then people who can't take an mRNA vaccine have something to shift to.
Thanks so much, Allison. So, so many, so as we've been talking about vaccines, I will just say that Allison and Liz have answered lots of questions within the Q&A. So please check those out if you haven't had a chance to as yet. I know Abhishek and David are starting to do so as well. And then I also, just wanted to shift the conversation a little bit back to the in-person versus virtual, because there's been this incredible chat discussion about it. I think I'm going to just take a moment here to read David Dane's comment, if I can find it now, because I think it was a comment that resonated with a lot of people. So just going to find his comment. But I think what we're seeing, is a lot of people are worried, what if my staff are not being vaccinated? Is it really fair to bring people in the office? And then I think David Dane here said, if the science is that we must continue our IPAC procedures as per November 2020 or for longer, then the inefficiency that causes must be recognized by our system partners. We can't be measured against 2019 in-person visits with current IPAC requirements still in place. So, I mean, I think that's a great point that I think all of us would agree with. I think that one other piece that's sort of come up is in the Q&A and the chat is just sort of, what do we do for people who are symptomatic? Can we see those people in person or not? And I guess I will say that, you know, my understanding is that, of course, symptomatic people still need a COVID test, but you can still see symptomatic people in the office if you take the right precautions, and sometimes it's appropriate to do so if you need to do, for example, a physical exam, and you think probability, for example, of other things needs to be ruled out or is high. So I think that's, I will say that when we've done some surveys of physicians' practice patterns, you know, maybe 25 to 50% of visits are in person, but a lot of people are not seeing symptomatic people in person at all. And perhaps that's something, as testing centers close, we need to think more about. How can we do that safely while still offering COVID tests? And I don't know if Liz or Abhishek, you want to comment on that.
Maybe I'll start, and Abhishek, you can kind of chime in, and we can sort of try to get at it together. I was just going to point out that, so the guidance in November is what's being updated right now. What was released in June, though, was information from Public Health Ontario about what changes if somebody's fully vaccinated in terms of testing and IPAC and PPE. And maybe Mina could put that in the chat. It was for the hospital and long-term care sector, but I think importantly that did say, just to your point, Tara, if somebody is symptomatic, even if they've been fully vaccinated, you need to do the same testing, follow those procedures, and on IPAC and PPE does not change. So there are sort of some very minor changes around fully vaccinated and they're asymptomatic, but for symptomatic, it remains the same. I think the in-person for those who are symptomatic is something that's going to depend on the community resources you have, what your office looks like. Do you actually have that space where you could, put somebody in that room by themselves if they're symptomatic and isolate them from everyone else? I think I'd be interested, and maybe that's what's happening in the chat right now, about what people are doing across the province in that regard and how they're managing bringing in symptomatic people. But I think, I am looking ahead for sure to the fall flu season and what we know is going to happen with an increase in ILI and other types of infections, and how are we going to manage that? I think the question of the testing centers closing, testing and assessment centers, I mean, my hope would be that we continue to offer those options, because I think it is going to be hard for us to be seeing those, all those symptomatic patients in our offices right now with everything else that we're needing to do, and the care deficit around, some of the other pieces that I put up on cancer screening, et cetera. So we haven't yet heard that from the ministry that the testing and assessment centers are going to wind down, in the same way that we have definitely been hearing that from them that the mass vaccination clinics are going to be ramping down. So those are just some of the signals that we're hearing. So I don't know, Abhishek, what your experience is around those symptomatic patients and how you're dealing with them across your practices.
Yeah, I mean, it took us some time to get with the protocol for that, because obviously it was quite challenging. So we have our screening questionnaire, but it's modified. So it's cough and fever. And if it's cough and fever, that's a high clinical suspicion. But if it was just cough, just sore throat, usually we don't worry too much about that. From the staff perspective, yeah, we do ask all our staff to be double vaccinated. And so that also kind of decreases the overall risk of transmission during the clinic there. And finally, just for seeing those symptomatic patients, so there's a moderate degree of clinical suspicion, but not a high degree of clinical suspicion. We use full PPE, so it's all the way from gowns, gloves, and face shields, and N95s there.
Thanks so much. So, I mean, I think we could continue this virtual in-person discussion for a while. There's lots of nuance there, but I'm going to turn it over to you, David, because I want to make sure that you have time to tell us about the new reports that family doctors are getting. So, Brian, are you able to pull up the slides where we left off, maybe?
And maybe while he's doing that, there was a really upvoted question around funding for virtual. I think there's like 22 upvotes. So as many of you know, and you saw in the question from Dr. McLean, the funding that was extended in the spring by the ministry is supposed to expire September 30th. So obviously up to the ministry and the OMA negotiating committee to extend that further. I will bring people's attention, because I think it came up in one of the other questions about, can I use FaceTime? If you remember at the beginning of the pandemic, because of the rapid shift to virtual, we were told, use a secure solution, but if it's not secure, given the situation, that's okay. Over the course of the pandemic, Ontario Telemedicine Network at Ontario Health has been going through a virtual visit solution verification process. I just realized I posted the wrong link. I'm posting the link in the chat. There are a number of solutions that many of us already use that have been verified, and I know a number more will be verified this month. So the ones for like Telesuite, Maple, other ones that I hadn't even heard about, Banty Medical, for instance, is another one. But basically, we're not endorsing any of these at Ontario Health, but the process really means that these have met provincial standards for virtual visits, both for either e-communication or video. They're safe, secure, patient privacy is protected, and likely in the future, though it's going to be up to the ministry and the OMA, these are the solutions that are going to be available for provincial program funding, similar to when it was just using the OTN solution. So important link to check out and keep an eye on if your solution's not there yet. It likely will be in the next 6 weeks or so. If it's a pretty, most of the well-adopted solutions are going to be certified, I would think, this month. So something to keep an eye on and may be important after September 30th. So thank you for giving me the...
David, I'm just going to actually go back 2 slides here, because I just want to make sure, Brian, can you go back? Yes, perfect. Because I just wanted to provide this context of where we are at. We are doing fantastic, but we are at about 68% in Canada with first doses, 39% with double vaccinated. But that still means that there are, over 30% that haven't gotten the first dose. And I think this is, the real importance of what you're going to talk to us about right now. So Brian, you can go back to David's slide now.
Yeah, so I think the context, and some of the other folks that are either panelists or on the call spoke to this in the media yesterday, is that primary care has been, since the end of December, has been really one of the backbones of our vaccination effort. Maybe not in our offices, but definitely as a workforce in long-term care and mass vaccine clinics and retirement homes. And in our offices, I think there's upwards of 500 or so offices that have had vaccine in their offices. But what we're thinking about now, when you look at that graph that Dr. Kiran showed, is now we're asking for another skill set, right? Now it's not just our ability to give a vaccination, but it's our ability to use our trusted long-term relationships with our patients as family doctors to help boost vaccine confidence. And a couple months ago, I suggested to the ministry that we really need to release to primary care providers a report that would tell them who was not vaccinated in their practice. Same way that we release this information for cancer screening. Unfortunately, lawyers get involved, and the lawyers in Ontario felt that we cannot release information about patients who have not yet received a health service. You can't disclose that somebody didn't get something, even if you're in a patient enrolled model. We can do that for cancer screening because there's special regulations that allow the former Cancer Care Ontario to withhold that information. So many of you have seen that OMA kindly circulated the section of general family practice, kindly circulated this memo from Dr. Sasha Bacha and myself, and just reminding people or telling people that this is coming and that you would need to use your OneID account. We know that the vast majority of family doctors in comprehensive care have OneID accounts. We also know that about 600 or 700 of them have not logged in about a year and their password is locked. So we wanted to remind them, and it's important to reset their password so that when the report is available, they're able to get it without delay. We can go to the next slide. So this is a mock-up of what the report will look like. Now, the report is just a report, but we work with our system partner, Ontario MD, which you'll see in a minute, to really add the magic here. So in this report, you can see this is on the front end of the report, you can see that the SAR, the Screening Activity Report dashboard, is in the same place. So when you go to get your cancer screening, this is in exactly the same place. And you can see the last dose of vaccine that a patient in a patient enrolled model in your practice has received. And then you see there's a little floppy disk icon right in the middle of the page. You can click there and actually download this report, which is what's going to be the most important, in a comma separated value format. If you click on a patient's name, is the equivalent of me saying next slide, you can actually see the detail on the next slide of this individual patient, obviously not a real patient, of both of their vaccinations. So you can see, this patient get an AstraZeneca first and then a Pfizer, or 2 Pfizers, or did they get a vaccine outside of Canada that's now been uploaded to COVAX on. So that's helpful, except that really what we want to focus on is, who hasn't been vaccinated. So if you flip to the next slide, our partner at Ontario MD worked with us to create a workbook for each of the major EMR providers. And so this, I'm trying to see the chat as it pops up. So patient enrolled models include fee-for-service models like family health groups, CCM, FHO, FHN. So the only physicians, there's about 8,000 comprehensive care family physicians that will receive this report. The only physicians that we can't release this report to right now, because we don't have data matching the patient to a physician, are people who are in straight fee-for-service. And that's just a technical issue more than anything else. It's not that we don't want to release it, it's that we don't have a special database that links those patients to a primary care provider. So in this toolkit, one for each EMR provider, all the instructions are inside the Excel file. And there's a number of tabs in that Excel file. One of them is a tab to download your patient list from your EMR. The third tab is to download the list that you saw on the previous screen. And you'll see what that magic looks like in a minute. And then probably one of the most important things are the resources and tools to help you build vaccine confidence in your patients and change ideas to think about how would you reach out to them, either by phone or by mass email using a secure Canadian, not a secure, but a Canadian certified solution like I think a Cyber Bond would be, or Cyber Impact would be one where the servers are located in Canada. So if you go to the next slide, this is what the download will look like. So really minimal information, the information that you saw on the web page. And then you would just paste that information once a month into the Excel spreadsheet. And then the magic happens in the tab with all your patients. And if you go to the next slide, it matches the information that you downloaded from your EMR to the information in the list. And 2 things will happen. So you'll see no vaccine reported in the patients that don't get, who have not yet received a vaccine. If the vaccine is from outside of the country, you'll see Donald Trump here receive Sputnik V, and but it was inputted into COVAX on, so we were able to find that out. The other thing, that magic that the folks at Ontario MD added, is some logic. And so if a patient got their first dose of Moderna, and now it's been over the monograph, it will highlight that patient's overdue. So you can actually also see which of your patients who've already received a first dose are also overdue. You could sort it by dose administered to then attack, sort of attack the people who are either the oldest or the people who it's been the longest time since they've been overdue for their vaccine. So probably very important thing that we can use our skills as family doctors to do is contacting those patients, especially those who are older, who have not yet received a vaccine. One thing to note, you'll see in that one patient who it says no vaccine reported, it also doesn't say that I'm the enrolled provider. So this will only show up for patients that are rostered to you. In this case, Mr. Randy Hill isn't rostered in my practice. So even though it says no vaccine reported, he may have received a vaccine, but the government can't release it because he's not rostered to me. So I may have to call Mr. Hill either way. If you go to the next page, oh, that was it. My apologies. So Happy
so
to
much,
take,
David.
yeah, no problem. Happy to take, I know we're running close on time, so happy to take any questions offline.
Yeah, so David, first of all, thank you to you and others who have just worked behind the scenes tirelessly to try and get this to us. I know it's not been easy, and you've had to create these workarounds for us to be able to get the list of the unvaccinated, and I know you've really been committed to that. So thank you, first of all, for that leadership. I also just wanted to ask to clarify, people are wondering what models, so is it including CHCs that are going to be getting this? So not CHCs at this time?
I'll come off. Yeah. So basically, any model that's captured in something called the CAPE database, which is the rostering match between family doctor and patient. We do have the ability at Ontario Health to match people virtually. So even the patients who are not yet rostered with you, but you've been providing care, we know that based on OHIP billing data. We are going to continue to work with the ministry to see if they will allow us to include the virtually rostered people in this report. But right now we can only, we went ahead with what was the easiest thing to do, which was the people who are rostered. So anybody who receives a
Can you speak also to the funding issue, David, and whether people will get actually paid for calling their patients?
Yeah, for sure. So obviously we still have virtual care funding if you're going to have an extended visit, just like now, if you knew that a patient of yours, for whatever reason, you reached out to them and you asked them if they'd been vaccinated earlier in this effort, and you spent time with them on the phone, obviously there's a virtual visit fee. There is a separate code, I believe it's a Q700 or a Q007, I can't remember, which the ministry or public health has to ask us to formally reach out to our patients. I know that the ministry, I feels that if we're sending, if they're sending lists via Ontario Health, the idea is that family doctors should reach out to their patients, and we're working with them to have a shared communication when this report gets released at some point next week, which will hopefully clarify that. But I believe it's either $6 or $7 per patient that you reach out to, that you help facilitate booking. So the other question that we're asking clarity on is, can this be delegated? So if your secretary or nurse reaches out to a patient and helps them book about, and if it's just a matter of facilitating, like they don't even have any questions for you, and then your nurse or secretary is able to help facilitate booking them a vaccine, whether or not that delegated act, you'll be able to bill that code for. So we'll all get that clarity in the next couple of weeks.
So thank you so much, David, and thanks to all our panelists today for an excellent session. There's so much to talk about as usual, from ramping up to balancing virtual in-person care, seeing people in person who might be symptomatic, calling people proactively, and then of course all the vaccine questions that just keep on coming, and the new evidence that's coming out. So thanks to all of our panelists, David, Abhishek, Allison, McGeer, to my co-host Liz Muggah, and to our team behind the scenes. And thank you again for everything that you continue to do. It is summer, and I hope that you are getting some time off and some time to recuperate with your family, despite all of the work that we still know has to be done. But take some time off for yourself, and we look forward to seeing you next on August 20th. So we are ourselves taking a bit of a summer break, but we'll be back on August 20th ready to answer your questions, fill out the evaluation, and let us know what you want to hear about for that next session. Take care.